Thank you for joining us today for this bonus video in our focus series on hypertension. My name is Zach and I'm a member of the Atrium Cardiology Collaborative. And this video today is going to focus on 2017 guideline updates for the management of hypertension. To give you a little bit of background on the hypertension clinical practice guidelines that were just published, this was a comprehensive guideline update, so it included more than just recommendations on management of high blood pressure, but also included recommendations on prevention, detection, and evaluation of high blood pressure. This was the first of its kind since 2003 when JNC 7 was released. This was also a collaborative guideline that involved 11 different organizations. So in addition to the American College of Cardiology, the American Heart Association, organizations such as the American Pharmacists Association were also included in this guideline update. Now as we dive into the new guidelines, what you'll see as one of the key differences is how we're classifying hypertension. And with the new guidelines, significantly more American adults are going to be diagnosed or classified as being quote-unquote hypertensive. Roughly 30% of American adults were hypertensive under the old guidelines. With the new guidelines, that's increased to about 45%. On the left-hand side, though, I've shown you the old guidelines and their classification, and then on the right-hand side, I've showed you the new guidelines. And what you'll see is that there's really no difference in how we classify normal blood pressure. It's still less than 120 over 80 millimeters of mercury. However, what has changed is how we classify patients with quote-unquote pre-hypertension under the old guidelines. In fact, that term isn't even used in the new guidelines. The term has been replaced with quote-unquote elevated blood pressure. And you can see the systolic blood pressure is 120 to 129, and the diastolic has to be less than 80 millimeters of mercury. Stage 1 and Stage 2 hypertension are where there's some more significant changes. So Stage 1 hypertension in the new guidelines is considered a blood pressure of 130 to 139 over 80 to 89. And then Stage 2 hypertension is considered anything greater than 140 or greater than 90 millimeters of mercury. I also want to mention that as we talk about classifying and diagnosing hypertension, the new guidelines place a great emphasis on out-of-office blood pressure monitoring. Now that we've talked about classification, let's talk a little bit about pharmacologic management for those with hypertension. So with the new guidelines, who warrants treatment for hypertension? Well, anyone with stage 2 hypertension, so blood pressure 140, systolic greater than 140, or diastolic greater than 90, would warrant pharmacologic treatment. And then anyone with stage 1 hypertension who has clinical ASCVD, or atherosclerotic cardiovascular disease. So these are your patients with stage 1 hypertension and have had a prior myocardial infarction, a stroke, peripheral vascular disease, etc. In addition to that, in patients who have stage 1 hypertension and a 10-year ASCVD risk score of greater than 10% would warrant pharmacologic treatment. Now, for those who fall in the stage 1 hypertension and have a risk score of less than 10%, they do not necessarily need to be on pharmacologic treatment. Lifestyle modification alone may be sufficient. Another change with the new guidelines is that the treatment goal is almost across the board less than 130 over 80 millimeters of mercury. Now, for practitioners, this is a much simpler way of targeting a goal as opposed to the old guidelines, which were based on comorbidities, age, and things like that. So by and large, the treatment goal is less than 130 over 80 millimeters of mercury with the new guidelines. If we take a look at what the new guidelines recommend for pharmacologic management of hypertension, thiazides, calcium channel blockers, ACE inhibitors, or ARBs are all considered first line. Now, of note, within the thiazides class of medications, chlorthalidone is actually given preference based on more favorable pharmacokinetic profile, longer half-life, and perhaps better clinical trials data. As with the old guidelines, though, comorbidities still do impact which therapies are chosen for management of high blood pressure. As you can imagine, patients with heart failure and a reduced ejection fraction are still going to need to be on their guideline-directed beta blocker, ACE inhibitor, etc. for management of their blood pressure first. Patients with heart failure and a preserved ejection fraction who are exhibiting symptoms of volume overload will probably do better with a diuretic first. Those with chronic kidney disease or diabetes with albuminuria should be receiving an ACE inhibitor, and those with aortic disease should receive a beta blocker. A few other key updates as it relates to the management of hypertension. In patients with a blood pressure greater than 20 over 10 millimeters of mercury above goal, they recommend starting 2 agents initially. In addition, in our older adults, the target blood pressure is less than 130 over 80. This is different than the former guidelines, which suggested a more lenient approach of less than 150 over 90. And then lastly, but certainly not least, the guidelines support using a multidisciplinary collaborative approach to managing patients with hypertension. And indeed, pharmacists were included within this as a valuable asset to the healthcare team in helping manage patients with hypertension, ensuring that they're compliant and adherent, have access to their medications, etc. That wraps up our brief update on the hypertension guidelines of 2017. Thank you for viewing this video. I'd encourage you to subscribe to our YouTube channel and catch the other videos in our hypertension focus series, Under Pressure. Thanks.